Hello, everybody. Happy Monday. What a great way to kick off the week with a great conversation. I'm going to give everybody just a second. I still see some people getting connected. We're really excited to have you join us for this Lunch with Docs today with renowned movement disorder specialist, Dr. Espay. Before we get started, I want to encourage you to go ahead and open up that chat box. You guys are all experts by now, but just on the off chance that someone might be new to Zoom, if you hover at the bottom of your screen, you'll see a little toolbar pop up, and kind of in the middle of the screen, you'll see the little box that says chat. Pop that open and then give me a shout out and tell me where you're joining us from, because I love finding out where everyone is at, and we get people from all over the United States. We even get people in other countries, and it's just great to see where everyone is tuning in from. And this is where you're going to be asking your questions today, and I know you're going to have them. So we're going to invite you to go ahead and put your questions in the chat. And then as we go through the conversation, we'll pull out some of those questions and answer those as we go along. Well, at least Dr. Espay will. And I want to go ahead and get started because this is a very important topic. And I know Dr. Espay has a lot to cover. So I just want to give a brief introduction of him for those of you who may not have met him before or seen him online, but he is a renowned movement disorder specialist. He's professor and endowed chair of the University of Cincinnati James and Joan A. Gardner Family Center for Parkinson's Disease and Movement Disorders. He is a prolific researcher and author. He's published over 200 peer-reviewed articles, 25 book chapters, and 5 books, including Brain Fables, which I actually see on his bookshelf behind him. And we've had him online before with Dr. Indu Subramanian and Ben Stetcher talking about Brain Fables. So maybe you've been lucky enough to have caught that. And if not, you can go into our archive and watch that because it's a very interesting program. His research focuses on the measurement of motor and behavioral phenomena and clinical trials for Parkinson's disease, as well as understanding and managing functional movement disorders. And what I really love about him is that he likes to approach Parkinson's and other neurodegenerative diseases, kind of like we do cancer, that it's very very much by that person's own specific needs, and it's not a single disease, but many individual molecular diseases. It's a mouthful. So really well educated and an expert in this. So I'm going to welcome you, Dr. Espay, and start us off because we want to know what is autonomic dysfunction, because that's what we said we're talking about today related to neurogenic orthostatic hypotension. So can you start us off by explaining that?
Yes, thank you, Anissa, for the kind introduction. I'm delighted to see so many people from so many different places. Wow, this is so well attended. I'm just thrilled. And good to see you all. I'm glad that at least I get to see you in a little squares here on my computer. That makes it so special. Autonomic dysfunction is a term that we use to imply that the part of the nerve system that has to do with the automatic functions, we call them autonomic, but automatic functions are all those related to things we don't think about: heart rate, blood pressure, breathing rate, sweating, bowel movements, right? Those are the things we just don't play anything about. We're not planning. Those are happening. Some of those, of course, we can plan, but these are, of course, things that are regulated separately from other parts of the body. And the autonomic system happens to be affected in many individuals with Parkinson's disease. And one of the ways in which it expresses is both in terms of changes to the heart rate control and changes to the blood pressure control. The heart rate control loss means that the heart rate is no longer speeding and slowing according to the different changes to activity. And then the blood pressure loss of control expresses by too high or too low blood pressure readings. What we call neurogenic orthostatic hypotension is only one end of the spectrum. It is really related to the fact that blood pressure fluctuates through the day. Sometimes it's high, sometimes it's low. When it's low, we use the term hypotension. But most people with hypotension that's neurogenic, meaning that's due to a damage to the nervous system, such as that occurs in Parkinson's disease, will also have hypertension. In both cases, paroxysmal, meaning that it never stays low because it's going to go up, but it never stays up because it goes down. So that's important because it will provide us with a framework to understand how is it that we think through this problem and how we can treat it.
So you mentioned neurogenic orthostatic hypotension is related to problems such as Parkinson's. So, and you mentioned orthostatic hypotension. So how do you differentiate between the two? Because they're similar, right? They're the same thing, but not.
Exactly. So essentially what we then do typically in a clinic setting is that we check the blood pressure, ideally lying down, but it could be sitting. So people would have had to stay in that position for at least 3, if not 5 minutes. Then we have the individual stand up, wait a couple of minutes, and get both the blood pressure and the heart rate again. Orthostatic hypotension is defined by the drop in blood pressure of greater than 20 in the systolic, the high number, or greater than 10 in the diastolic, or the low number. The higher that difference between sitting or lying and standing, the greater the magnitude of the hypotension, and usually, but not always, the worse the symptoms. And we'll talk about those exceptions later. Now, the term that's opposite to orthostatic hypotension is supine hypertension. So you're going to hear these two terms, orthostatic hypotension. Orthostatic just means upright, erect hypotension. The minute that individuals are up, the blood pressure drops. Remember, when you stand up, your head is going to be further away from the ground, and the forces of gravity would mean that the blood pressure would have to do a better job in sustaining the blood pressure, in making it higher, because it is required by gravity. Because it is autonomic insufficiency, that doesn't happen, and that's why the blood pressure almost consistently in individuals with autonomic insufficiency drops. Supine hypertension means that when you're lying down, that's a supine position, your blood pressure is above 150, 160 in the systolic. The numbers change depending on what definition you use, or greater than 90, the low number, the diastolic. So how many people have documentation of both? Technically, it's about 70%. In reality, it should be 100%, because if this is neurogenic, the problem is never that the blood pressure is too low, but that the blood pressure is changing, and that it can be sometimes too low, but it can also be rather high. Now, the immediate danger that is brought on by low blood pressure exceeds the immediate danger that can be brought on by paroxysmal hypertension. And this is the first concept worth emphasizing. There really is no risk that we know of, or at least it has been studied, that in individuals who happen to have autonomic insufficiency, the risk of any hypertension is in any way equal to the risk of chronic hypertension, which we all know is high, because people with hypertension at all times can have heart attacks, can have strokes, can have kidney infarcts, right? So they can have a variety of different things. We know that, but that's not what happens to the hypertension of neurogenic orthostatic hypotension. That's paroxysmal, and the best treatment for that is to stand up. because of what I just mentioned, that the minute you stand up, if you worry about your blood pressure and you just wait just a couple of minutes, you will most likely be reassured your pressures are down.
Wow. So how common is this in Parkinson's? And I heard that it's also pretty common in other Parkinsonisms. Can you speak of that?
Yeah, it is very common. The prevalence, that is the frequency at any point in time, is about 60% of anyone with Parkinson's. So it's more common than not for people with Parkinson's to have this in some level than to not have it. And it is much more common in Parkinson's and the conditions that are related by virtue of what we call synuclein loss. The synuclein protein is what makes conditions known as synucleinopathies. Parkinson's is the most common of the group, but there are also other conditions: dementia with Lewy bodies, Parkinson's disease dementia, and multiple system atrophy. There is something else called pure autonomic failure, and that is not a condition that includes any motor features. So we never see individuals with that, but they're also in the synucleinopathy basket. But of all of these conditions, Parkinson's is the one that this is most common in. Now, how we make diagnosis is often because we ask patients, when you stand up, do you feel that you might pass out? Do you feel lightheaded? There is something funny that happens when you stand up. And when individuals say, yeah, I feel a little lightheaded, then we screen for it. And we often find it. That's the most common explanation for anybody feeling woozy-headed on standing. But it actually is present in 40% of people who don't tell us that they are lightheaded, which means that we only are getting into about a third of patients because of we're just essentially at the mercy of whether people feel lightheaded, and if they do, we screen for it. But in fact, there is some more individuals that aren't endorsing lightheadedness when in fact they do have orthostatic hypotension. Very important, because in the future we should really be looking at measuring blood pressure sitting and standing, or lying and standing, in everyone, so that we're not missing anybody with this particular complication.
And we had a question, when or do you typically perform a tilt table test for this, or do you just need to do the sitting and the standing?
Yeah, it's a good question. No, we typically don't need the tilt table unless we're going to be evaluating a person for a widespread dysautonomia, when we think this is more than just blood pressure. We think is the bladder, we think it's the sweating system, we think is the heart directly with the heart rate, etc. But we really don't need to do that, because the elements to make the diagnosis are achievable without a tilt table. And essentially, by the way, the blood pressure drops. And what normally happens when the blood pressure drops in someone without Parkinson's is that the heart rate goes up as a compensation. So the blood pressure is down and the heart compensates by beating faster. The lack of compensation reflects that autonomic insufficiency. So how we make the diagnosis of neurogenic rather than just bread and butter orthostatic hypotension, which can come from just dehydration, is that the blood pressure drops, but the heart rate doesn't go up in compensation. There is not compensatory tachycardia. The blood pressure it goes down and the heart rate stays the same. That's how we know it's neurogenic. And that information is something that we can glean from just the bedside testing of blood pressure lying or sitting versus standing.
All right, well, I'm getting several questions related to that. So one of them is, can you have that lightheadedness even when you're sitting? And the other one is, what is the timing of taking the blood pressures from sitting and then standing? And then I know I keep adding to these questions, but it makes me also wonder, can there be a delayed onset of symptoms after standing more than just the like immediate? Like, can it be like 30 seconds, a minute, or whatever? So I know it's threw a bunch of questions at you.
Oh, no, Anissa, those are three great questions, really. The first is a very wise question. We're calling it orthostatic hypotension because we're saying the minute somebody stands up, that is what happens. But the autonomic insufficiency dictates that the position change isn't needed. So absolutely, whoever was thinking, could this happen sitting? Yes, it can happen when you're not moving the position at all. It's technically non-orthostatic hypotension. It's a paroxysmal event because this blood pressure happens in the background through the day, whether or not you're standing or not. When you stand, you magnify the problem. But because the problem is there in the background, then you can be sitting and feel something is changing because the blood pressure is coming down. What are those things you can feel? Not just lightheaded. You can feel fatigue. You can feel foggy-minded. You can feel lethargic. You can feel like you want to sleep. You can feel like you want to lie down, right? Any of those symptoms can come on, and it can be exactly this situation, even though you're not standing. The second question is, how long would it be before you kind of make the second measurement to define orthostatic hypotension? Typically, it's 2 to 3 minutes. Because that includes 80 to 90% of everyone. But there is such thing, and this is then relevant to question number 3, those who have delayed orthostatic hypotension. That's the term when the blood pressure drops not within 3 minutes, but about 5 minutes or sometimes a little longer. And those are harder because we would not tend to screen for them at the bedside. We just do the 2 to 3 minute standing. And if individuals are within that 10% where they would have the condition in a delayed fashion, we would actually miss them at the clinic. So that's a problem. In the future, I think that we would have to have a system whereby we measure this in the clinics, and then we would want to keep on measuring this also out to 10 minutes. So we would get the patient two minutes up. After 2 minutes up, then blood pressure, then 3, then 5, then ideally 10 if at all possible. 10 would be maybe overkill, but 5 would be at least something worth aiming for, because it could still uncover a small but significant number of people with this condition.
All right, so you talked about dizziness. You talked about fogginess, like just fuzzy brain, maybe a little confusion. Can you feel like other sensations, like a prickly kind of feeling? You mentioned fatigue. Are there any other signs or symptoms that people might want to look out for?
Yeah, so it is really a very large spectrum of symptoms. One that we worry about is freezing of gait. Freezing of gait, you often think is related to periods when the levodopa isn't working well, but it may have nothing to do with it. And if it doesn't, it's sometimes related to periods when the blood pressure is low. So freezing of gait and falls are symptoms of OH. We, by the way, define symptomatic OH exclusively on the basis of whether there is endorsement of lightheadedness upon standing. But most people, as I mentioned earlier, don't have that. So 40% do, 60% don't. And that means they're going to have other symptoms. That's not to say it's asymptomatic, but we call it asymptomatic only because people have not been telling us that there is a situation of lightheadedness with that. but those other symptoms are just as relevant. So in my mind, just about everybody's symptomatic if we expand the concept. So sometimes it can be headache. The other very important sign that people might experience is back pain, and particularly upper back pain, neck pain. Coat hanger syndrome sometimes is referred as. So critical to know that some people can have double vision. Some people might have difficulty with speech, more dysarthria, as we call it. Some people can experience depression or anxiety. So when you start looking at the range of manifestations for this, these are big. So I think that perhaps the most important message here is that if there are changes in you that are happening in a rather dynamic fashion, where you are experiencing something for half an hour to an hour, then you're back to where you were considering yourself baseline. Then later in the day, you go again into another funk of whatever type you call it, right? Foggy mindedness, not speaking well, feeling depressed, etc. If it's fluctuating within a day, that is going to be an important clue to search for orthostatic hypotension, even if you don't have the classic manifestation of lightheadedness upon standing, because you don't have to stand, as somebody wisely pointed out earlier. So I hope that this is helpful. We have good days and bad days, but if we have good times and bad times within a day, then that's something that is a very important red flag telling us that we might look into or need to look into OH.
All right, we're getting tons of really good questions, and some of them I think you're covering, but you mentioned, and I want to go back for just a second because you mentioned freezing a gait. So I had a question if there's any correlation of other symptoms, like is there a relationship to those who might be more tremor dominant versus somebody who might be more postural and gait impaired? Is there a correlation?
Loosely, there really isn't a very robust correlation. It is something that tends to occur more often among people who don't have a tremor than those who do, but the violations to that rule are many. So I don't think it's clear to say that orthostatic hypotension, in general, autonomic insufficiency would cluster most often among individuals with a specific motor set of presentations. I think in general, it could be tremor, not tremor, freezing, no freezing, etc. But because, and this is something I hope that we're gonna come into a little bit in more detail later, there is a relationship between it, the hypotension, and a variety of other symptoms. Then those other symptoms, including motor difficulties, we mentioned about freezing, for instance, then it's very important to at least do a careful evaluation at some point. And it'd be important to bring up to your doctors that you participated in this particular session and that you think is so common, it's worth having that measurement, because there could be a great deal of improvements on something that you prior to the session would have attributed to levodopa dosage imperfections.
Yeah, and I would like to get into some more in regards to other issues, dysautonomia. So somebody had written in that they have sweating and temperature regulation problems also. They were thinking maybe it was menopause, but is there, like, if you have one issue like NOH, are you more susceptible to having a variety of other autonomic nervous system issues?
Yes, so NOH could be the proverbial tip of the iceberg. It could tell us that there is dysautonomia and that it may not be the only manifestation of it. So you're correct that individuals who do have OH may also have such autonomic manifestations as urinary urgency or frequency, They might have constipation. Constipation tends to be a lot more common, but it is an autonomic manifestation. They could have sweating pattern dysregulation. They can have inappropriate tachycardia or inappropriate bradycardia, slowing of the heart rate during exercise, etc. There could be actually changes in breathing patterns. Now, the latter, we're recently recognizing that while it actually reflects an underlying autonomic manifestation, an autonomic deficiency, it might be regulated with some changes in levodopa dose. So levodopa has some effect in some of these manifestations. People who have shortness of breath that are happening cyclically, most often as the medication wears off, for instance, is a manifestation of autonomic insufficiency, but it can be mitigated or sometimes eliminated completely by an adjustment in the levodopa dose.
Great. So, and that was a question, like, can it be tied to off? Will this worsen when they're off? So,
yeah, some of these do. Now, some of these worsen during on, and that has to do with the fact that levodopa itself is a medication that drops the blood pressure. So both Parkinson's as a result of autonomic insufficiency, as well as the treatment for Parkinson's, levodopa particularly, although all other dopaminergic treatments can lower the blood pressure. So one thing to think about, and this is related, I saw something very briefly, somebody said OH versus NOH, right? Can you have just orthostatic hypotension and not be neurogenic? Yes, you can, and that could be often drug-induced. Which are the drugs that are going to do this more often? Well, levodopa, just mentioned, but also people who have come into Parkinson's disease with hypertension to begin with, a history of chronic hypertension. So one silver lining of Parkinson's for people who have had hypertension is that their intake of antihypertensives might need to be eliminated, which provides us an opportunity for medication simplification. So even if you have NOH, neurogenic orthostatic hypotension, you might have a component of it that is non-neurogenic, that is related to either the levodopa or other medications that drop the blood pressure, particularly if you had hypertension. And tamsulosin is absolutely right. That's another medication for bladder that could drop your blood pressure and could be a reason why individuals continue to have symptoms despite our best attempts. So when we try to think of treatment, one of the earliest things we need to do is to see if the dose of levodopa needs to be as high as it is. Sometimes it needs to be, so we have to deal with it. And see if there is any other medications, antihypertensives or bladder medications that have been grandfathered into your regimen because before you had Parkinson's, you had hypertension or you have bladder problems. If you have any of those medications, then the first order of business is not to add a medication to increase your blood pressure, but to eliminate a medication or medications that have contributed to lowering your blood pressure, that have contributed to the OH without the neurogenic component.
It sounds very complicated. So aside from the movement disorders neurologist, do you need a cardiologist to be involved to manage this?
That is such a great question, and it's a difficult one. And I'm going to explain to you why that's difficult and why I'm so glad you asked that question. So we neurologists are all about quality of life. And I think we think of the brain as being who we are, right? So without brain, there's nothing that could happen to us. So we try to think through that as much as possible. Now, to a cardiologist, the cardiologist, as you can imagine, is all about the heart and the vessels. So cardiologists think of hypertension in any flavor as bad. We don't. We think hypertension in the context of autonomic insufficiency isn't that big a deal. In fact, there has been no study that has shown that it is associated with heart attacks or strokes in the manner that chronic essential hypertension is known to do. But cardiologists are not aware of this literature. And so what happens is that, remember, I told you that your blood pressure is fluctuating through the day. So is there a medication that can narrow the fluctuations? And the answer is no. Nothing can narrow it because the problem is structural. The problem is that there is a problem with the regulation, and there is nothing that brings that regulation back. So the treatment approach is to ensure that you're not fluctuating down here, but that you're fluctuating up here. And therefore, what we are aiming for is not to have any degree of hypotension. We probably still have some, but fewer of those, even if we'll have more episodes of hypertension. So the success in the program is in the ability that we have to tolerate intellectually, because the body doesn't have any problems, but intellectually, knowing that some of our numbers are high. But if we allow that to happen, then your hypotension, which I said at the outset, is the clear and present danger. That's what's going to get you to freeze and fall. That's what's going to keep you mentally foggy. That's what's going to make your communication poor. That's what's going to make you fatigue. That's what's going to make you try to just lie down. If we want to eliminate all that, which contributes to quality of life, then we might need you to think of accepting the idea of more episodes of hypertension. These are just episodes. Now, what happens if you tell us, neurologists, that you're having too many of those and that you're worried? You're calling us now and say, my pressure is very high. The recommendation we neurologists would give you is stand up, wait 2 minutes, measure your blood pressure again, and guess what will happen? You'll be, that's it, that's a treatment, you'll be reassured, right? What would a cardiologist do? A cardiologist would review your medication and say, oh, but you are on a medication to raise your blood pressure. That's the problem. We're going to get rid of it. In fact, we're going to put you on an antihypertensive because I think that you have just too much predisposition to hypertension. So what happens between neurologists and cardiologists is that unless we really get to know each other within our centers, we are in a constant battle between us saying, let's allow some hypertension in order to avoid the clear and imminent danger posed by the hypotension. The cardiologist would say hypertension of any flavor, no matter how transient it is bad. We don't want it. We would rather keep patients hypotensive. Now, that's at the expense of quality of life. And so what discussion we have with our patients, with my patients, is I said to them, let's say that there is a risk that the cardiologists think there is for you. And let's say that because we're going to be more liberal with allowing your blood pressure to rise so as to prevent the hypotensive episodes, that you might die in 5 years instead of 10. That's just hypothetically, right? But with a better quality of life, because you will not be fatigued, you will not be depressed, you will not be fallen, you will not be, et cetera, right? You'll be so much better. As opposed to living 10 years, but mostly living out of a gurney, because the minute you're going to get up, you're going to feel that you don't feel good, right? So I bet that most people will choose, oh my gosh, I don't want to live too long miserable. I want to live shorter, but better, right? Most of us feel that way. So I'm glad you asked that question because it's very critical. There is often that issue between neurologists and cardiologists. Neurologists looking for how to improve quality of life, even if it creates some risks, and cardiologists mitigating any kind of risks, especially if it in any way looks like hypertension.
All right, that is so helpful, I think. And I just want to go back and reiterate because it is a complicated conversation. So to recap, this person says, so Parkinson's episodic high blood pressure is not as dangerous as regular chronic high blood pressure, but cardiologists think it is. So they just want to make sure they're tracking it. So exactly. That's correct. Okay.
Exactly.
And, I earlier had a question come through in regards to stroke risk. I mean, is there any additional stroke risk because
No,
of this constant up and down, or does it potentially reduce
not
the
really. So what's very interesting is at a population level, the stroke risk in Parkinson's is lower than in age-matched controls, meaning people who are the same age that don't have Parkinson's. We don't know why that is, but it's interesting. And if we're saying, well, if autonomic insufficiency is so common, and we presumably see a lot of this blood pressure going up and down, shouldn't then be that there are so many episodes of hypertension that we should see more strokes, but we don't. It doesn't happen. That's not to say it's never happened. No, it happens. But at a population level, that is epidemiologically, as we speak, there is no evidence to suggest that the stroke risk is higher in Parkinson's by virtue of both the disease and how we treat it. So no, the answer is there is no risk. And again, you would think by now, because hypotension doesn't come alone, but comes with hypertension in a fluctuating pattern or an alternating pattern, that hypertension, if it was going to be relevant from a complications perspective, by now we would have known.
And I had a really good question that came to me directly, and they want to know white coat syndrome. Does that play a role? And I have that every time I get my blood pressure taken at the doctor's office, and I'll say, give it a minute and then take it again, and it'll be normal. And it is. So is that even an issue or consideration with all of this up and down?
Not really. No, the up and downs is not going to be related to the white coat syndrome. The white coat syndrome could temporarily increase the blood pressure in any of us without necessarily invoking autonomic insufficiency. It's a measure of stress. You are a little stressed when you're in the office, and that's what happens. Which is why I don't use white coats, by the way. That's why this is how you see me here, is how I look in the clinic. I'm not with any white coats, but I wouldn't blame the white coats on any of these issues we're discussing here today.
All right. So I want to get into a little bit about treatments, and I know there's been some questions that I will go back to, but you know, fall risk is huge. And I shared with you before we got on camera with everybody that I had someone in the past that I've worked with that fell so hard because they just literally stood up and they had a delayed response. They stood up to answer the door. They started towards the door and they had almost gotten there. They fell, blacked out totally, fell and hit the ground so hard they broke their jaw. So that is a huge quality of life issue, because now we're talking hospitalization, potentially rehab for some, and kind of a low spiral that we don't want to see. So first, can you talk a little bit about the fall risk, hospitalization, and the impact on people?
Absolutely. So I was mentioning to you, Anissa, earlier before we came to the session that this issue we're talking about today is the lowest hanging fruit, because it is lurking in so many people, and so many of us don't know that our patients are having this problem. But it is perhaps the most important correctable, reversible risk of falls and freezing and depression and fatigue and cognitive impairment. And so if you have any of those symptoms, imagine that you are discovered to have this problem. It could be that this is going to reverse any of them or all of them. So the risk of freezing and falls is very high with orthostatic hypotension. Even if you say, I have no symptoms, meaning, do you feel lightheaded? You say no. In fact, the argument we are making is that having no symptoms is worse, because by not having symptoms, first, we're letting other things happening that we're not attributing to the OH. But number two, because what happens is that the lack of endorsement of lightheadedness means that this has been happening for so long that your brain has adjusted to it, that it no longer can sense the blood pressure falling. It doesn't sense it. So even though we sometimes measure these really large drops in blood pressure and ask people, how do you feel? About the same, no difference. That's kind of bad. We want symptoms to happen in there of like, oh yeah, I can feel it. So that then we are alert, but because nothing happens. And the next thing we know is exactly what you mentioned, Anissa. It's a fall, right? Sometimes that's how we learn people have this problem, because they're falling. And so if we recognize this as one of the correctable, reversible causes of falls, freezing, depression, cognitive impairment, fatigue, etc., that would be very, very important. But sometimes we just come to learn about it since there have been no symptoms, at least not traditional symptoms, a little bit after a complication has emerged.
Okay. Boy, I have so many good questions. We could probably talk for 2 hours. I had a question that I want to go back to, and then I want to talk about treatments. That we mentioned MSA earlier on, and this person wanted to know if someone is a non-tremor PD, they don't have a tremor, and they have NOH, is it potential that they might have MSA and not Parkinson's? And what are some telltale things that they would be looking for to differentiate between MSA and Parkinson's when they both can have similarities?
Yeah, great question. It's not an easy answer because a lot of the distinction between Parkinson's and MSA requires a very careful neurological evaluation. But how could we suspect, in the absence of a careful neurological evaluation, that what you see as NOH is part of MSA instead of Parkinson's? Well, the first thing is that this is only one of many clear autonomic manifestations. So people also have bladder neurogenic, it's called neurogenic bladder. So not only urgency and frequency, but incontinence. They may have neurogenic bowel. They may have incontinence of bowel. They would have changes in frequency of the heart rate. It's called the loss of heart rate variability, although that would be hard for you to pick up on. But an important one is autonomic dysfunction at the capillaries. And that creates in the hands and feet a reddish, purplish discoloration that may come on at different times of the days. And it makes the hands and feet look mottled. So that would be one way to tell. So it's, as you can imagine, autonomic issues that happened to be well beyond OH, and that might, in fact, spread through other organ systems.
Yeah, so I want to talk a little bit about treatments. So first, let's do discussion around some non-pharmacological treatments, some things that people can do just at home, adjusting maybe behaviors, diets, adding things. What do you suggest?
Yeah, so that is a great way to start the discussion on treatment. The first thing is to get rid of that which you don't need. And so we talked about medications that may not be needed. It really is a silver lining. I have very few patients with Parkinson's that after 5 to 7 years still are on their antihypertensives. So that's one thing that ends up coming off of, because we know that it may in fact be a liability. You think of your levodopa as your antihypertensive if you had hypertension to begin with. Somebody mentioned tamsulosin earlier, so that's an important one, very common in the regimen of people that needs to come off as well. Then in terms of what's referred to as non-pharmacologic interventions, what we like people to think about is to increase the intake of water, or other non-caffeinated beverages. Caffeine tends to be a bit of a diuretic, and that's why it's not considered a hydrating liquid. So anything without Caffeine is best. Water, of course, probably may be ideal, but Gatorade or other products without caffeine will be just fine. Though not to just rely only on them, because I think then that could create some problems with the concentrations of electrolytes. Salt is very important. Most people are told do not have salt, right? Because most often the concerns has been with hypertension. But remember, since that isn't a concern here, then salt is just fine. If you happen to have grown accustomed to not having salt in your meals, and sprinkling with salt is impractical, then you can have salt tablets that are available over the counter. You can have 1 gram of salt tablet with each meal, for instance, and I think that would be very helpful. Meals are, when large, inductors of hypotension. The term that's used in the medical literature is postprandial hypotension. Why? Because large meal makes the blood flow centered around the stomach and the bowels, the small bowels and the colon. And that means that less blood flow is elsewhere, including the brain. So when are the most vulnerable times for people with autonomic insufficiency to have hypotension? Right after a big meal. So a possibility could be then that you might have smaller meals, but more frequent, so that they are never too large, and that could then do away with the possibility that this would create problems. And then there are some exercises that you can do to mostly hold on to your legs in such a way that it increases the abdominal pressure a little bit, but those are really hard to do. If you've done these things and there still is a problem, there's one more solution before going into medications that you could consider that is very effective, but is kind of bothersome just because it's just it requires extra effort. But that is thigh-high compressive leg stockings. Those are a pain to put on, I have to admit, but the larger the pain, the better they are at keeping the blood pressure up. So if you have an easy job with any of these leg stockings, they're not doing the work. So they have to be just hard to put on, because they are literally tightening, putting a lot of pressure on your legs, and that creates that situation where much less blood is pulled in your legs. Most of it is coming up and helping the blood circulate in other areas, particularly the brain. Not infrequently, I have had people who I thought I would need, no pain, no gain, very good, Nick, the medications. And when they, in fact, get to a point where they use this thigh-high, not knee-high, thigh-high compressive stockings, that's not needed. So it can work really well if you put the effort, and you might then, the advantage of that is that you might not need medications. So those are the non-pharmacologic approaches. Any questions about those?
I was just going to ask if an abdominal binder is helpful. I live in Florida. We've got people that are in Arizona. Sometimes it's just too hot to put those thigh highs on. So is that an option?
That's an option. Yes, that can be used. The question is it good alone or in combination? And I think that alone could do, but in combination is even better. It's combination with the thigh highs, compressive stockings. Good question. Now, if you are at a point where these strategies aren't really quite panning out, then the strategy would be to start something. So you've excluded all the medication, or eliminated the medication that can lower the blood pressure. You've optimized the levodopa dose. You've then taken more salt, taking more water, and you're using thigh-high compressive stockings. Well, then there are several medications that could be used. The one that most often is used is called midodrine. Midodrine starts with a low dose, 2.5 milligrams, 3 times a day. It's increased all the way up to 10. Some people use 15 and can do better. Fluorocortisone is another medication. Fluorocortisone works different than midodrine. Midodrine kind of gets the vessels to tighten a little bit, so it increases the blood pressure that way. Fludrocortisone is as if you were taking salt because it just retains fluid. That's what fludrocortisone does. And then there is a newer medication called droxidopa, which recently came off license, made by Lundbeck. And so that one is now available as a generic, and I think it's going to be much more accessible. It was very expensive when it was under license. So those are the three. There are more medications, but those are the three first-line agents. And not uncommon, people don't do well enough with one, and then we need two. And if two don't work, then three usually do. But the message here is that this can be controllable in nearly everyone. So it really is a correctable problem. And you'll be so much happier if this is not an issue, if you're not at the mercy of blood pressure dropping because of all the issues we discussed earlier. So it's really worth getting it to be corrected, even if it takes 2 or 3 medications. Sometimes it's so helpful because it makes a very, very big deal of impact on your quality of life and overall function.
All right, so I had a couple of questions related to those who have like arrhythmias, AFib, tachycardia. Like if they had a pacemaker, they wanted to know if there's less chance of falling, if it's to correct bradycardia. Another wanted to know about AFib or arrhythmia. Is it something that is impacted by levodopa, and do they play a role in all of this?
Good question. It's not impacted by levodopa, but yes, they do play a role. So if people do have rhythm disorders, atrial fibrillation that's severe enough could in fact be a major reason blood pressure is dropping. Other rhythm disorders can have the same problem. So if that's happening, that they need to be corrected if they're relevant. If sometimes atrial fibrillation, for instance, is mild and it's not that big a deal, can be managed with medications. But if it's severe enough, I think an ablative procedure is going to be needed to eliminate that problem so that it doesn't interfere with the control of the blood pressure.
And I just had a question. A couple of people are commenting, spouses on midrogine and droxidopa. Can you take 2 meds together?
Yeah, you can. You can. Never start 2 medications at the same time, and you should never do that. But if one has been tested and it doesn't seem to work enough, then a second one. Now, if one is taken and it doesn't work at all, then I discontinue that medication and put individuals in something else. So adding another medication on top of a medication that doesn't work is not worth doing. But adding a medication on top of a medication that does something but not enough is okay. And sometimes 2 medications can work better than one. But we have to, by doing this on a staged fashion, we have to document that the first medication is doing something, albeit insufficiently, before moving on to adding a second medication.
All right, and I've had a couple of questions, and I think this is interesting. So wearable devices, is that promising for preventative measures? And is there really anything that someone can do to prevent or help alleviate before this becomes a problem?
It's a great question, and none of the wearable technologies, to my knowledge, are able to measure this. We ourselves have a wearable technology that we're using on a research basis called an ABPN, ambulatory blood pressure monitoring. But to my knowledge, a version for the consumer has not been released that I know of, although I would think technology is out there and perhaps it is already available somewhere or will soon be. But at the moment, really, the only strategy to look at this is to just do the old-fashioned blood pressure cuff. If you have a blood pressure cuff at home, do this. Again, if you want to be very sensitive, don't start with the sitting position, start with the lying down position. Have the person you're measuring lying down for at least 5 minutes so that is the position, the blood pressure that you're collecting is not one that belongs to a different stage, but it's just the blood pressure that would happen during lying down where the gravity effects are zero. And then after you've measured blood pressure and ideally heart rate, then have the individual you're measuring stand up, wait 2 minutes at least. You can wait a little longer. And then again, blood pressure cuff, you just get the blood pressure and the heart rate. Remember, the heart rate is important because I think I saw another question that came out recently with somebody asking again how to distinguish between OH versus NOH. The neurogenic version of OH is one where the heart rate doesn't go up. And that's how then the heart rate is important because it distinguishes the blood pressure dropping that relates to neurogenic when the heart rate doesn't move versus the one that's non-neurogenic, say dehydration when the heart rate goes up, typically in compensation.
And we're getting low on time, but I think this is a good question. Someone wanted to know if blood pressure has any connection with hallucinations or myoclonus.
Okay, so directly, probably not, but indirectly, maybe. We've seen that the most severe situations of hypotension, of neurogenic orthostatic hypotension, occur in individuals who have other problems. And so dementia, psychosis, as you mentioned, myoclonus is an expression usually of dementia. Myoclonus, for those that don't know, is a quick jerk. So tremor is a rhythmic activity, but another kind of jerk is the myoclonus, which is non-rhythmic. So if you look at somebody and the movements are rhythmic, as opposed to a tremor where they're rhythmic, then that is typically not a feature of Parkinson's, except that dementia has appeared, in which case it could be the case, or medications are inducing the jerk in the myoclonus. The most common medication that induces myoclonus in Parkinson's is amantadine. And amantadine is something that has a window. It's really working really well as an antidyskinetic or for tremor early on. But if people have any tendency toward cognitive impairment, amantadine can make that worse and make myoclonus happen. And so if you see myoclonus, make sure that amantadine is not part of the regimen, because if you eliminate that, it's going to get a lot better, as well as improving cognitive function too. So that's very important. So I hope that answered that issue. No, directly probably isn't the case, but we know that orthostatic hypotension is a problem that's much more likely to occur in individuals who have other problems. And in that situation, of course, trying to optimize it will be even more critical because of the state of vulnerability.
All right. And just kind of getting towards the end and recapping. So water, very important. And most of us are not drinking enough anyway. So of course they want to know what would be enough to be sufficiently hydrated daily.
Yeah, the trick that I use as an average is no fewer than 5 8-ounce glasses a day. And because it's hard to kind of keep a tally on, I like people to think of having 5 different colored glasses, so that you've covered the yellow and the blue, but you have yet to cover the red, the purple, and the indigo. So I think that's a way to kind of remind you have not covered all your 5 glasses. It's a fun way to complete your liquid intake for the day.
Awesome. And then one last question was, once you start these compression stockings, do you have to wear them all the time?
No, good question. Do not wear them at night. So I mentioned that during the day, individuals are fluctuating, right? And that we just want to make sure that there are very few episodes of hypotension, even if at the expense of more episodes of hypertension. But one thing that happens at night in individuals with daytime OH is that at night they tend to be hypertensive. How do we know that? Well, we know that because studies that have been done on blood pressure monitoring during the night shows that that's the time. Remember, now you are eliminating gravity, right? So the blood pressure goes up because you have no gravity to fight against. How do we know, practically speaking, that because you're going to be measuring blood pressure at night? The way you can tell is because you're getting up too many times to urinate. When the blood pressure goes up, the kidneys get a sense of, oh my goodness, blood pressure is up. I need to get rid of volume. So your kidneys kick into overdrive, and your bladder fills up and fills up. And so you get up 3, 4, or 5 times a night, which of course is disruptive of sleep hygiene. The second thing that does is that it then will put you at a big deal of disadvantage first time in the morning, because now you have NOH plus OH, right? You're dehydrated. So your OH is severe in the morning. And so the first thing you have to do is getting a big glass of water. But the prevention is, do not use the high compressive stockings before bedtime. Make sure that the last dose of midodrine or fluorocortisone or droxidopa is no later than 4 p.m. because you want the effect to wear off before the nighttime. And if that still happens, and there are 2 strategies, one non-pharmacologic, elevating the head of the bed so that you have a little bit of gravity, and that keeps the blood pressure from rising too high, or adding a bedtime dose of a short-acting antihypertensive. That seems weird to say. We're talking all about trying to raise the blood pressure, but sometimes the best thing that we can do to help blood pressure during the daytime is to attenuate the rise in blood pressure at bedtime, so that then you're not compromised in the morning with too low hydration levels. And importantly, guess what happens? Your sleep hygiene will get better because you're going to be getting up fewer times to urinate.
Awesome. Well, I have to say, and I agree with David Cox, this is simultaneously brilliant yet understandable, and such an important conversation. And I want to encourage everybody, if you have had any of these symptoms that he's discussed today and you haven't shared them with your doctor, I need you to go do that immediately.
Yes.
And I don't know if you have any parting words of wisdom that you want to share with the group, Dr. Espay.
Boy, I just really wish that you understand how important this topic is, how much in the way of opportunities for improvement there are. And do not worry about hypertension in Parkinson's. That's not a big deal. It's always going to be episodic. There is no chances it will hurt you. I mean, probably nothing is risk-free in life, but the greatest risk is in letting hypotension lurk in the background and be causing a variety of things that perhaps you may not be even aware that it is related to. Those things are related to the hypotension. So a big opportunity for improvement here, maybe, as I mentioned, a low-hanging fruit that can be corrected. And so I hope that these concepts were helpful. And I know there were too many questions to deal with. I'm pretty good at emails. You can also email me if there is a list of other questions. Maybe I can have a list and try to answer them in the best way I can. Thank you, Anissa and Kelly, for the invitation. And it's been wonderful to be with you all.
Well, and we're so thankful for your time. And we have a tradition here at PMD Alliance that we thank our wonderful speakers with our wave of gratitude. So I know everyone wants to thank you for this fantastic program. If you want to go back and listen to it again, because I know there was a lot of information, it should be up on the website within the day or so. Go back and review it. He gave you a lot of information on here. It might be helpful. Dr. Espay, thank you so much. Everybody, have a wonderful day. Thank you.
Great to see you, everyone. Take care.
Bye-bye.
Bye-bye.